Let's skip the pleasantries and jump right into the clinical algorithms you need for test A. In this explainer, we're extracting pure cardiology decision logic directly from the USMLE Step 2 and 3 inner circle notes. We're going to focus heavily on valvular murmurs, dynamic maneuvers, and high-yield complications. Let's get to work.
Section 1. Aortic Dissection Triage Logic.
Picture this. A patient presents with abrupt onset severe tearing chest or back pain, and their blood pressure is just sky high. If you suspect an aortic dissection, your absolute first move, before you even think about imaging, is to administer anti-impulse therapy. You've got to reduce that aortic wall shear stress. Think IV beta blockers like Esmolol. Only after you've controlled the hemodynamics do you confirm the diagnosis with a CT angiography, or if they're hemodynamically unstable, a transesophageal echo. From there, the decision tree is super straightforward. Type A dissections involve the ascending aorta, so they require emergency surgical repair. Type B is confined to the descending aorta, meaning medical admission for strict blood pressure control.
Now, what's incredibly high yield here is how the branching anatomy literally dictates the clinical complication in your test vignette. It's like a map. If the dissection shears off the carotid artery, the patient develops a stroke. If it extends proximally down to the aortic root and valve, you're going to see sudden hypotension and pulmonary edema from acute aortic regurgitation. And what if it hits the pericardium? That's a life-threatening tamponade. Trust the anatomy. It'll hand you the diagnosis right there.
Section 2. Mitral valve, regurgitation and stenosis.
Let's shift over to the left side of the heart, starting with mitral regurgitation. Now, chronic MR slowly creates a volume overload state, which leads to progressive left ventricular dilation and eccentric hypertrophy. But listen up, test A questions absolutely love acute MR. If you've got a patient presenting post-myocardial infarction with a sudden, brand-new hollow systolic murmur at the apex, your differential has to instantly prioritize ischemic papillary muscle displacement, which happens pretty much immediately, or a full papillary muscle rupture, which typically hits a few days later.
So, how do you know exactly when to operate for severe primary MR? Well, surgery is indicated the moment symptoms appear. Or, and this is a massive, highly tested trap, when the left ventricular ejection fraction drops to 60% or lower, even if the patient claims they feel perfectly fine. It's absolutely crucial to remember that durable valve repair is heavily favored over replacement, mainly to avoid lifelong anticoagulation. On the flip side, secondary MR is generally managed medically.
Conversely, keep your eyes peeled for mitral stenosis. If your vignette describes a young or middle-aged patient from a developing country, or maybe they have a rheumatic history, presenting with dyspnea, orthopnea, or hemoptysis, tune in closely. The physical exam is a dead giveaway here. You're listening for a loud S1, an opening snap, and a mid-diastolic rumble at the apex. You also want to watch for ECG signs of left atrial enlargement, like P mitrale, or even voice hoarseness. That hoarseness is known as Ortner syndrome, and it's caused by the massively enlarged atrium compressing the recurrent laryngeal nerve.
When you spot this, your immediate next step is always an echocardiogram to measure that transmitral flow velocity and gauge the severity. From there, the definitive treatment logic branches to either a percutaneous valvotomy or a surgical replacement.
Section 3. Aortic valve, regurgitation and stenosis.
Let's move to the aortic valve and build our differentiation strategy. We need to separate a volume problem from a pressure problem. In chronic aortic regurgitation, backflow from the aorta into the left ventricle increases the end diastolic volume. This creates a massive stroke volume and a distinctively widened pulse pressure. This exact mechanism is what gives you those rapid rise, rapid fall water hammer pulses, perfectly paired with an early decrescendo diastolic murmur. And remember, in younger patients, always suspect a congenital bicuspid aortic valve as your underlying cause.
Now, for aortic stenosis, the whole presentation flips to a pressure overload issue. The classic demographic here is either an elderly patient with calcific disease or, again, a younger patient with a bicuspid valve. You're looking for the classic symptom triad: exertional angina, syncope, and heart failure. On the physical exam, your buzzwords are a soft delayed carotid upstroke, that's your pulsus parvis et tardis, a soft or a single S2, and a harsh crescendo-decrescendo systolic murmur at the right upper sternal border that radiates straight up to the carotids.
Your triage logic for aortic stenosis is pretty straightforward. Step 1. Confirm the severity with echo criteria. Step 2. Once severe AS actually causes symptoms, or if the ejection fraction falls under 50%, you replace the valve. But Step 3 is a critical safety rule you literally cannot miss on test day.
Strictly avoid treadmill stress testing in severe AS patients. It is an absolute contraindication, no exceptions.
Section 4. Dynamic Maneuvers, AS versus HCM.
Board exams absolutely love to test the differences between similar presentations, right? So let's contrast aortic stenosis with hypertrophic cardiomyopathy. Both of these feature a systolic murmur, but they behave very differently under stress. Decreasing preload with a Valsalva maneuver decreases the blood volume in the left ventricle. For HCM, less volume means the outflow tract gets even more obstructed by that thickened septum, so the murmur actually gets louder. But for aortic stenosis, less blood crossing that stiff valve simply means a softer murmur.
You can also easily differentiate them right on the basic physical exam. Aortic stenosis features a soft, delayed carotid pulse because the blood is just struggling to get past that calcified valve, and you'll often hear an accompanying ejection click. HCM, on the other hand, presents with brisk carotids due to an incredibly forceful initial ventricular contraction, and you will absolutely never hear an ejection click. Use these structural clues to lock in your diagnosis fast.
Section 5. High-yield cardiac complications.
We're going to wrap up our triage overview by looking at some highly lethal cardiac complications where immediate recognition literally saves lives. So picture this. Your aortic dissection patient suddenly develops severe hypotension, jugular venous distension, and pulsus paradoxus, which is a fall in systolic blood pressure of greater than 10 millimeters of mercury during inspiration. What deadly complication just occurred?
The answer is cardiac tamponade. The dissection has ruptured backward right into the pericardium. If you grab a stat ECG, it'll reveal exactly what you're looking at here: electrical alternans with sinus tachycardia. The amplitude of those QRS complexes is alternating from beat to beat because the heart is literally swinging back and forth in a sack full of fluid. When you see this, your immediate next step is emergency pericardiocentesis.
Finally, let's lock in your post-MI pharmacology. Every single post-myocardial infarction patient, whether they got a stent or not, must be discharged on a strict medical regimen. We're talking dual antiplatelet therapy, a beta blocker to reduce myocardial oxygen demand, decrease the risk of arrhythmias, and inhibit remodeling. They also need an ACE inhibitor or ARB, and of course, a high-intensity statin to stabilize those atherosclerotic plaques and slash the risk of a recurrent MI.
And this brings us to our final takeaway. Trust the objective findings. Isolate the buzzword, whether that's an opening snap, an ejection click, or electrical alternates. Evaluate exactly how the hemodynamics shift with dynamic maneuvers, and commit to the algorithm. As you face these vignettes, ask yourself, if a single dynamic maneuver, like a Valsalva, can completely change your diagnosis, are you relying on vague intuition, or are you trusting the physiology? Master these algorithms, and you won't just ace the exam, you'll be the one catching the life-saving diagnosis on the wards. So what other clinical algorithms are you second-guessing right now?